Waalaikumsalam. Yes, doctor.
Okay, all right. So last week, unfortunately, I forgot to record lecture. Okay, so basically last week I talked about type 1 hypersensitivity, and this week I'm gonna talk about type 2 through 4. Okay, hypersensitivity reactions. Okay, so I'll go quickly, okay, on type 1 hypersensitivity, okay, since I forgot to record last week, okay. So just I'm not gonna go into detail, okay, because we still need to actually cover it, okay, cover the type 1, type 2 to type 4, okay. So just briefly, right? So so basically, okay, we have the 4 types of hypersensitivity. Okay, so as I mentioned last week, okay, type 1 through 3. Okay, so type 1, 2, and 3 are antibody mediated. Okay, so only that type 1 is IgE. Okay, mediated. Type 2 and type 3. Okay, mediated by other Igs. Okay, so the difference, okay, between type 2 and type 3, if you see here, is IgG, IgM, but the antigen is on cell surface, okay, versus type 3, the antigen is soluble antigen, okay. And then type 4, okay, is actually T cell mediated, okay. So for type 1, okay, it is called immediate hypersensitivity. Okay, so because first, okay, because okay, the reaction is immediate. Okay, once you are already sensitized to the antigen. Okay, so like I mentioned in my story last week, okay, when I was in the US, okay, first spring, okay, I was actually allergic to pollen. Okay, but the first spring I was just sensitized, okay, to the pollen antigen, right? So this is what happened, right? So first exposure to pollen, and then the APC, okay, activate the T cells, okay, particularly Th2, and then Th2 will produce IL-4, which will in turn activate the B cells. Okay, of course, B cell need to present the antigen to T cells, okay, for them to become activated. Okay, plus the IL-4 will cause the B cells to differentiate into and proliferate into plasma cells, okay, producing IgE antibody, as you can see here. Okay. And then what happened, okay, so during my subsequent years there, okay, so this is what happened, okay. So the IgE already on the cell surface of the mast cells, okay, and also basophils also have these features, okay, where IgE was on the cell surface, okay, because of the sensitization, okay, occurring during the first time, okay. And then during the subsequent exposure, okay, the antigen, okay, which is in my case pollen antigen, will cross-link, okay, the IgE and cause the degradation of mast cells, okay, producing these molecules, okay. So these are all the molecules. They are pre-made, okay. Some of them are pre-made, means that they are already in the granules, okay. Once degradation occur, okay, so this will be released immediately and causing all these effects, okay. Okay, the one in white, okay, here are made, okay, after the activation occur, okay. So so that is for mast cells. Okay, basophils also produce more or less similar molecules. Okay, and then eosinophils will come in later. Okay, after mast cell and basophil activation. Okay, because for example, okay, the cytokines which are released by mast cell like interleukin 3, interleukin 5, the GM-CSF, granulocyte macrophage colony stimulating factor, okay, these cytokines will actually promote the eosinophil activation, okay, right? So once eosinophil is activated, then they will release this enzyme, okay? The red boxes, okay, are all pre-made, okay? So they are more potent, okay, in terms of their effect compared to the molecules released by mast cell basophil, right? And then the white boxes, okay, they are all made, okay, they are all produced after these are released, the red boxes are released, okay. So as I mentioned, okay, there are immediate versus late phase, okay. Immediate usually the pre-made, okay, the pre-made molecules that cause the immediate reaction, okay. As you can see here, this is the air that was blown out, okay. So there is antigen challenge on this patient, okay. So these are peak expiratory flow rate. So basically you need to actually blow, okay, onto this like chamber, okay, tunnel that will measure, okay, the amount of air, okay, that is flowing out, okay. So so you can see here, okay, the air, okay, the PEFR, okay, was actually depreciated, okay, just few minutes after the antigen challenge, right? So this is because of the pre-made molecules effect, okay, and then it goes back to normal, and then later, okay, few hours later, it will actually go down again, okay. So these are all the molecules that are released after, okay, basically after the activation of mast cell or eosinophils, okay. So because these effects, okay, the effects of these molecules actually have different effects, okay, on different organs, but is basically what are the effects that are seen also in parasitic infestation, okay. So these are the characteristic of IgE that characteristic of allergens, okay, that will drive the IgE responses, okay. So IgE is also called reaginic antibody, okay, REAGINIC, okay, antibody. So the route of allergen entry determines the effect, okay. So if it's low dose, usually is local effect, but if it's high dose, okay, for example, injection of peanut antigen, okay, some of individuals actually are allergic to peanuts, okay. So even a small amount of peanut, okay, it can cause actually what we call as anaphylaxis, okay. Or if the allergen is introduced intravenously, okay, it will cause systemic release of those molecules, which will cause systemic anaphylaxis, okay. Right, so these are all the common diseases, okay. So in systemic anaphylaxis, because of the molecules are released in the blood, so the effect are more severe, okay, and can cause death. So immediate treatment, okay, we can give epinephrine, okay, or adrenaline, okay, the same thing, which will help, okay, to increase the blood pressure, okay, to reverse the anaphylactic reaction. So these are all the common diseases of hypersensitivity and therapy, okay, of type 1 hypersensitivity. Okay, so and then the skin testing, you have intradermal skin testing, you see here, okay, you inject certain amount of certain allergen, and then you see whether there is reactions there. So these are called the anaphylactic reaction, okay. So these are human, okay. This is dog, okay. So you can see the human actually, okay, is allergic to feather, cat, dog, okay, horse, okay, and some amount of plain pollen, okay. Right, so other than intradermal skin testing, you can perform also ELISA, okay. So ELISA means basically you need to actually take the serum and then measure the IgE. So the thing about ELISA is that the IgE half-life in the serum is short, okay, only a few hours, 3 to 5 hours. So let's say that the animals are introduced into to the allergen. Okay, so if you miss the 5 hours period, okay, so probably you measure the IgE like at 8 hour, okay, post antigen, okay, exposure, then you will miss the IgE level, okay, so you will get false negative, right? Okay, so let's move on to type 2 hypersensitivity reaction. Okay, so type 2 hypersensitivity reaction, okay, is what we call a cytotoxic hypersensitivity. Okay, remember cyto means cells. Okay, because the the antibody are reacting with the epitopes on the cell surface of tissue. Okay, the host cell surface or tissue. Okay, so so it cause, okay, there will be absorption of antigens or haptens to the cell membrane or to the tissue. Okay, so the classic example of type 2 hypersensitivity is, okay, the absorption of antigen, okay, or haptens to the cell membrane of the RBC, right? So for example, penicillin, okay, so if you are actually because penicillin, okay, can actually attach, okay, to the RBC, okay, once it breaks down, okay, so it will actually absorb on the cell surface, right? So once it absorbs on the cell surface, the body will recognize the RBC as foreign, okay, because it doesn't recognize the component of the penicillin that is on the cell surface. Okay, what happens next is the antibody will be produced against, okay, the penicillin, okay, component which is on RBC, okay. So the complement will be activated and then cause the RBCs to be lyse, okay. Other than that, okay, complement other, so this is through the MAC pathway, right? Remember, membrane attack complex. So complement can also act as opsonin, all right? So it will actually attract those phagocytes like macrophage, okay, that will actually engulf, okay, the RBC. Okay, other than that, okay, because there is antigen antibody complex, okay, so it will actually activate the action of natural killer cells, okay, through the antibody cell mediated cytotoxicity, right? So I hope you still remember NK cells. Let me try to draw. Okay, so let me try to draw on the okay. Okay, so you can see my screen, right? Okay, so let's see. Okay, so this is just something that I played around last week. Okay, because it's very difficult to actually annotate, okay, to jot down on the screen, okay, using mouse, okay. So all right, so so just to refresh, okay, this is actually have been discussed over and over again, okay, in PBL, also in VPP 3231, and also in viral immunity, okay. So just to refresh, okay, you have the RBC here. So okay. Okay. So you have the RBC here, right? Okay. And then you have the okay, the penicillin here, okay. And then So this is basically the antibody complex, right? Okay. And then okay, it will actually attach, okay. So there will be antibody attaching. Let me change color. Okay. So you have the antibody here. Okay. Remember this is FAB region, right? So this is the FC region, right? So and then you will have your NK cells. Okay. So NK cells. Okay. So you have your NK cells here. Okay. That have what we call as okay, the FC gamma receptor 3, okay, or CD16. Okay, so what happened? Okay, once it is engaged, okay, the ligand is engaged, then the NK cells will kill through what mechanism? If someone can answer that. NK cells kill.
Is it ADC?
Yeah, ADCC, and then what did it cause?
Apoptosis.
All right, so ADCC causing apoptosis. Good. Okay, so that is that, right? Okay. Let me share back the. Okay. So let's move to the next slide. Okay, so this is the summary of whatever in the previous slide. So you have the activation of complement, right? And then it will lyse target cells. Remember through the through the MAC. Right, to annotate here. Okay. MAC, okay, and then you have the complement can also act as opsonine, okay, and it will attract phagocytes, okay, which will engulf the target cells, okay. Now you have the NK cells just now, okay, that will engulf, sorry, not engulf, will cause ADCC, and also phagocytes, okay, it can engulf, not really ADCC, okay, so the phagocytes really actually is here, okay, destroy the target cells. Okay, all of this will cause, okay, cell injury lah. So RBC will lyse, okay, and then you will see the reactions in the individual, right? So in the end, okay, so when the RBC function, okay, is blocked, okay, or because it is lyse, okay, so the RBC function is actually compromised, okay, then it will change the function, okay, of the RBC. So it will no longer can carry the oxygen and supply all the organs, okay? All right, so common diseases of type 2 hypersensitivity, okay, the one that is very familiar to you all, you guys will also learn in physiology, okay, transfusion reaction. So basically, when you want to actually donate blood, okay, especially if you are, if you are O, okay, if you have the type O type of blood, okay, so you are the universal donor, okay, but you cannot actually receive, okay, from other type of blood, okay. So basically, if there is mismatch, so it will severely destroy RBC. So because we have naturally occurring antibody against other types of blood group, for example, if you have A blood group, so you have naturally occurring antibody against type B, okay. And then that is for RBC. Okay, so there is also transfusion reaction. That is non-hemolysis, means that it does not involve RBC, which is actually MHC. Remember, when you want to do organ transplantation, you need to also perform MHC typing. Allogenic MHC means the same species, even in the same species, even from one individual to another individual. Okay, that, as you know, MHC is has high polymorphism. Okay, from one individual to another, even among your siblings. Okay, you can have different MHC type. Okay, so this is very important to avoid transfusion reaction. Right. Other than that, hemolytic disease. Okay, this one in human, you have if the mother is Rh negative, rhesus negative. So you have first baby which is rhesus positive, and then so basically you will have antibody against the rhesus. Okay, and then when you have your second baby, then the fetal RBC will be destroyed. Okay, so in horse we see also the same condition. Okay, what we call as neonatal isoerythrolysis. Okay, I have picture here. So basically it involves AA. They have different blood type. Okay, blood typing. So they use the AA. There are other bunch of blood types in horses. Okay, so these are the one that actually usually commonly seen. Okay, that cause neonatal erythrolysis. Okay, AA blood type and also QA. Right. So so if the mare, okay, is AA negative, okay, and if the sire, okay, is the AA positive, okay. So let's say that the foal, okay, the first foal is AA positive. So during parturition, okay, there will be some amount of fetal lymphocyte that leak into the mother's circulation, okay, the mare circulation, which will sensitize the mare. So the mare will produce anti-AA antibodies, okay. So this antibody will be concentrated in colostrum, okay, but okay, it will not happen during the first parturition, means the first foal that has AA positive. So it will not happen during this time because antibody will take some time, okay, to be concentrated, okay, in the colostrum. Okay, so usually it happen during the second foal if the mare has the AA positive foal, okay, during second foaling. So when the second foal actually ingests, okay, the colostrum, so it will cause the antibodies to destroy the RBC in the foal, okay, and then cause hemolytic disease, right? Okay, so other than that, okay, blood parasites, for example, ehrlichiosis, okay, in dogs, okay, caused by Ehrlichia canis. So these parasites, okay, the same like penicillin, okay, it can actually absorb onto the RBC and causing the immune system to recognize it as foreign and destroy the RBC, right? So the penicillin I have touched just now, okay, on that. And I have the picture here. So basically it modified the red blood cells here with its beta-lactam ring. Okay, you can read further like what is the mechanism that the component of the drug that cause it to absorb on the RBC, but eventually it will cause the production of antibodies and then again, as I mentioned, that it will cause complement activation, causing the MAC, or also opsonin, okay, opsonization, and cause macrophage to phagocytes. Okay, so that is for type 2. Any question before I move on to type 3? Okay, type 3 hypersensitivity is also called immune complex hypersensitivity. Okay, the main difference is that the antibody is soluble, means it is actually in the blood, okay, or in the tissues, okay, freely flowing, right? Compared to the type 2, okay, the antigen is on the the antigen is on the cell surface, so the antibody is fixed on the cell surface, right? So when there is soluble antigen and antibody, okay, complexes causing inflammatory response in tissues. So you know that in normal reactions, okay, our bodies actually fight pathogens every day, right? So only that you could not see because you have functioning immune system that will form, okay, your antibody is working, okay, and then it will bind to the antigen. So immune complexes are formed and removed by the reticular endothelial system, okay, the RES. For example, the monocyte and macrophages in the lymph node, spleen, and liver will actually remove these immune complexes, right? So the disorders happen, okay, where the immune complexes are formed and deposited in tissues, okay. Usually you can see in virus and bacterial infections, okay. So immune complexes, okay, in this infection, they can deposited in various organs, okay, such as kidneys, okay, especially kidneys when you have, because kidney has small, okay, blood vessels, okay, and also glomeruli, okay, that can cause the immune complexes to be stuck there, right? So when there is okay, so these are virus and bacterial infection. Okay, in some cases, okay, there are also antigens, okay, which are self-antigens that cause the antibodies to actually binds to this self-antigen, okay. So this is particularly true for autoimmune disorder. So I will talk about it more in autoimmune diseases, but I will like to mention that there are some overlapping, okay, in hypersensitivity reaction on autoimmune disorder, okay. So for example, autoimmune disorder that can cause generalized, okay, immune complex deposition is like SLE, lupus, okay, systemic lupus erythematosus, okay. So it can cause immune complexes to lodge at the joints, okay, kidneys or blood vessels. So depending on the organs that they actually the immune complexes are deposited, so it will cause inflammation at that particular organ. So arthritis, nephritis, vasculitis. So I hope by now, okay, I think you already have your pathology, okay, lecture. So I hope by now you know that itis means inflammation, okay. So, all right. So let's go back to the annotation. I need to share with you, okay. All right. So, okay. So in normal condition, okay, we have, okay. So we have, when we have infection, okay, for example, we have different, okay, I will want to divide this, okay. So let's say that this is early stage, okay, this is intermediate, and then you have the late stage, okay. So during early infection, okay, so let's say that you have the antigen there, okay. So you have the antigen, okay, this is your antigen, okay. So what do you think during the early infection, antigen is more or antibody is more?
Antigen is more.
Sorry again?
Antigen is more.
Okay, antigen is more, right? So during early infection, yes, antigen is more, but you have some amount of antibody, okay? Probably, okay, you have 5 antigen but only 1 antibody, right? So, and then remember, okay, IgG, okay, it fixes, okay, IgG, actually, it 2 IgG per complex. Okay, so basically, for complement to attach to the IgG, to the immune complexes, it needs to have 2 IgG. Okay, not just 1 IgG. So 1 IgG cannot actually fix complement, right? So early, okay, you have this. Okay, let's go to intermediate. Okay, so what do you think about intermediate phase?
The antibody is more.
Okay, so there is actually a comparable amount of antibodies and antigen. Okay, so you will have, okay, so you will have, okay, okay, comparable amount of antibody. Okay, right? So in this case, okay, complement can actually fix it, right? Two IgG there, right? So what about during late stage? What do you think? Which is more?
Antibody.
So there is antibody more, okay, because the antigen has been cleared by the antibody. So you will have multiple antibodies here, okay? Okay, right? So this one probably I need to, okay, I'm scared. Okay, right? So, so you will have your, okay, your complement can fix here, complement can fix here, complement can fix here. Okay, so in this case, okay, okay, in the early case, okay, basically the immune complexes are small. Okay, so when the immune complexes are small, okay, and then because there is not enough IgG complexes, okay, that can actually activate the complement, right? So it will cause, okay, it will cause it to actually deposited, okay, on the basement of the capillaries, okay. So versus intermediate, okay, and large insoluble immune complexes, okay, so it will be eliminated by, okay, phagocytosis, right? But here, okay, because it's small and then not enough complement, okay, it will be,
Doctor,
sorry,
I cannot see the slide.
okay, let me share. What's the share button? Okay. Oh, okay. Share screen. Right. So it will deposit on the basement of capillaries. Okay. So it will actually cause complement to bind. Okay. But instead of removing it, okay, it will actually cause the C3A, C5A, to be cleaved, which is what do you understand about the A component versus the B component in the complement pathway?
The A attract cell.
Yes, A attract. Okay, so it is chemotaxis. Okay, so it will attract the neutrophils. Okay, so it will cause. Okay, sorry. See. Okay. Right. So it will cause, okay, the release of enzyme in the lysosome and cause tissue injury, right? So the same with it will also attract the basophil and mast cells, and you know that it will release all those molecules, okay, causing increased vascular permeability and causing the immune complex diseases, okay, versus the intermediate or the large immune complexes, it will be eliminated by phagocytosis, right? So, what are the common diseases of type 3 hypersensitivity? Okay, we have what we call local immune complex diseases versus systemic immune complex diseases. So these are all acute, means that once the antigen is cleared, okay, the reaction is stopped, okay, versus chronic immune complex diseases, for example, like lupus just now I mentioned, and also FIP, because the antigen is there, okay, all the time, so that's why it causes chronic, right, reaction. So in local immune complex, okay, the classical reaction that we can see usually is Arthur's reaction, okay, named by the person that actually discovered the reaction. So it will cause experimental local reaction, okay, necrotic vasculitis, so basically localized lah, okay. And then insulin dependent diabetes mellitus, so some people are actually have reactions, okay, against the insulin, all right. So but it is actually localized reaction, right. So example here, okay, so the injected antigen in was actually administered, okay, into this individual. So this individual that has IgG antibody against the antigen, okay, will then form the immune complexes, okay, and then it will activate the complement. So the C5a, okay, will actually call the mast cell, okay, to the site of reaction, okay, and then it causes the activation of the receptor on the mast cells, okay, that cause the induced degranulation, okay, then release of those molecules that will cause protein release, increased fluid and protein release, okay, from the blood, okay, into the surrounding tissues, okay, phagocytosis, okay. So that is local. So basically the antigen is injected based on the where it is injected, okay. So if it there is another one which is what we call as generalized, okay, as I mentioned just now, the systemic, okay. So this is actually the reaction that is associated with systemic type 3 reaction, what we call as serum sickness, okay. So during previous time, okay, we have for example like diphtheria, okay, or tetanus. So they use, okay, passive antibodies, okay, means that they injected antigen into an animal, okay, so it and then the animal produce antibody against the antigen, then they collect the antibody from the animal and directly actually administered into the human being, okay. So so this is what we call the foreign serum injection, okay. Now, okay, the one that is still seen, okay, passive antibody is what do you think? What do you think the treatment now that use antibodies, basically passive immunity? What do you think that people still use? Okay, diphtheria, tetanus, okay, people, I mean, we have stopped using antibodies, okay, directly. So we use vaccine antigen. So we have prevention against those using vaccine antigen. What about when you, let's say that you have snake bite? Okay, what usually people administer? Snake bite. Come on.
Then,
Sorry?
is it the snake venom?
So, snake venom. So basically you, okay, let's say that you got bitten, sorry. Bukanlah kena gigit dengan ular sawa, okay? Kena gigit, let's say that you kena gigit dengan apa tu? I cannot think about the, I cannot recall the name. Basically venomous snake bite lah. King Cobra kata. Okay. So usually you are administered with to counter the venomous snake bite.
Is it anti-venom?
Yes, okay, anti-venom. Okay. So you are actually got the venom, okay, from the snake bite. So you are administered anti-venom. Okay, so anti-venom is antibody against the venom. Okay. So do you know where does the venom actually produce? I mean the anti-venom, sorry. The anti-venom is being produced?
Is it from the snake itself?
Yeah, I mean the snake we take the venom antigen. Okay,
Yeah,
but then how do we actually produce the anti-venom?
Doctor, is it by getting the antibodies from other animals such as horses and sheep?
Yes, okay. So basically, usually for anti-venom production, they use horse, okay. Don't ask me why, okay. I haven't explored into that detail, okay. But when, okay, basically they injected the venom antigen into the horse, so the horse will produce antibodies against the venom, okay. So the antibodies are used as anti-venom that are stored in hospitals, okay. So the anti-venom will be actually injected. So these are the yellow is example of the anti-venom. So it's a foreign serum, right? Okay, so the antibodies contain antibodies is in the serum of the horse. So you injected the serum of the horse, okay, that contain anti-venom. So into the individual. Okay, so you can see here the yellow prick, and then you can see the red one. So the red one is the antibody against the foreign serum protein. Okay, so you can see here, okay, that when there is actually antigen antibody complex, okay, start to occur here when the antibodies are here, okay. So basically, okay, let me I think it's better to actually jot it. Share content. All right. Okay. So, right. So you have, oh my God, I don't know how to draw a horse, okay? It looks like dog, but whatever, okay? So you inject, sorry, okay. So you injected the venom, okay, right? So this causes it to produce antibodies, okay, against the venom, right? So you take the antibodies, okay, right? So you let's say that this individual, okay, is actually got venomous snake bite, okay, and then so basically you actually give the antibodies, okay. So person, okay, will so these are the antibodies. Sorry. Okay. So these are the antibodies, right? So these are the antibodies, okay, in this individual. What happened is that, okay, this person will make antibodies against the anti-venom, okay, because not the anti-venom itself, sorry, the component of the serum, because the horse serum, okay, contain other things as well, okay, not just the anti-venom antibody, okay. So it will actually produce antibodies against other component in the horse serum, okay. So that is what happened, okay. So when this occur, okay, right. So when this occur, okay, You can see here the yellow, okay, is the foreign serum protein, okay, and then you have the antibody, okay, in red starts to be produced against the serum protein, against the host serum, okay. So when and then you see the antigen antibody complex in blue starts to actually being produced, okay. So when it starts to be produced in the early stage, you can see that, okay, there is fever, vasculitis, arthritis, nephritis, okay, because of the reaction against those serum proteins, okay. But once, okay, the antibody is more, okay, here, okay, then there will be actually the reaction will be resolved, okay, because the antigen is no longer there, okay, and then the antibody is more, okay. So that is what happened, okay, in serum sickness. Okay, example, I mentioned just now chronic, okay, like SLE, okay, because SLE, when the individual, okay, has this condition where the immune response starts to attack own cells, okay. So bayangkan your immune cells starts to attack your nucleus, your chromosomes, right? So which are everywhere, okay, in your body. So you can see generalized reactions, okay, and then you can see all of these reactions in, this is example in human, okay. In dogs we also see lupus, okay, only that probably is underdiagnosed, okay, in dogs, okay, particularly in Malaysia. So we will get into lupus more in autoimmune disease, okay. And then we have type 4 reactions, okay, delayed type hypersensitivity, okay, which is, as I mentioned, type 1, 2 and 3 are mediated by antibody. Only type 4, okay, is mediated by T lymphocytes, okay. So it can be CD4 or CD8 T cells. So the response is usually delayed, okay, so that's why it's called delayed type hypersensitivity, begins hours or days after exposure to antigen, okay. And then for example, okay, the classic example of hypersensitivity reaction is tuberculin test, okay. In human we call it as Mantox test, okay. So if you are exposed to someone that is positive with tuberculosis, that has tuberculosis, okay, so usually get yourself X-ray and also Mantox test, okay. So in animal we call it as tuberculin test. So basically, if you want to determine whether the cattle are actually infected, okay, or vaccinated against Mycobacterium bovis, which is the culprit for tuberculosis, okay, in animal, to inject tuberculin, which is purified protein. So it's purified protein of the bacteria intradermally, so under the skin. So for 72 hours later, the induration and redness develops because of the reactions against the antigen. Okay. Other than that, you can see also contact hypersensitivity. I know that some of you, okay, probably are allergic to silver, right? Silver earrings or silver jewelry. So this will cause, okay, local epidermal reactions, okay, such as erythema, okay, vesicles, okay, on your skin, okay, because of contact hypersensitivity. So these are all mediated by T cells, okay. So you can see here, okay, the mechanism, okay, antigen is injected into subcutaneous tissue, and then of course APC will take it up, and then it will present to naive T cells, and then it will become activated and differentiated into Th1, and it will recognize antigen and release the cytokines. So and then these cytokines will actually recruit phagocytes, okay, to the site of antigen, okay. So what are all those cytokines? Okay, you can see the chemokines, okay, especially for the chemotaxis. And also you can see the pro-inflammatory cytokines like TNF-alpha, interferon gamma, which will activate macrophage and also release more inflammatory mediators, okay, and then cause local tissue destruction, right? So these are the mechanism, okay, in summary. So you have the antigen, for example, just now like silver or also tuberculin, which will cause, okay, T cells, okay, activation. So they will release all the cytokine and then you will see the effect, okay. And also they can also activate CD8, okay, which will cause target cells to be killed and then causing apoptosis, okay. And then you can see all this reaction which are actually inflammation, okay, characterized by the infiltration of those macrophage monocytes and also the tissue injury. All right, so these are tuberculin tests. Just now I already mentioned, okay, contact dermatitis, okay, these are all probably in human like pain, probably some animals, okay. I know that some animals probably are sensitive to detergents, okay. For example, if you actually mop the floor, okay, with some detergent, okay, some animals can actually develop dermatitis, okay, because of this type 4 hypersensitivity. All right, and then you have granulomatous reaction, FIP infection, okay. So FIP infection, okay, it has overlapping of type 3 and type 4 hypersensitivity, okay. Lupus, type 2 and type 3 hypersensitivity, okay, overlapping. So example, okay, of tuberculin skin test, okay, these are in human, okay, you can see that the antigen is injected under the skin, okay. And then these are again the same mechanism, only that this has cytokines, okay, here, just to actually give you a broaden overview, okay, on the effect, okay, because of the cytokines that are released, okay. And then you have granulomatous reaction, okay, in FIP reaction, okay, because okay, these are granuloma, okay. So you can see here, okay, these are actually macrophages, okay, that is actually engulfing the that has virus, okay, and then it has all these inflammatory cells, okay, and then also T cells here, okay, that is surrounding the virus that is inside the macrophages, okay. You can see this reaction in Mycobacterium as well, okay. All right, so in summary, okay, we have the type 1, type 2, type 3, and type 4. You can see is the immune reactant is IgE versus type 2, type 3, it can be IgG or IgM. Type 4 is T cells. And then you can see this is cell surface receptor. This is soluble antigen. And then you can see the different effector mechanism. Okay, and then the example of hypersensitivity reaction, these are more on human, okay, but you can add, okay, based on my previous slide, okay, for those that you can see in animals. So if you actually print this one out, okay, and then go through it, okay, you basically can nail my my question in test 2 and final, okay. So you just need to focus on this slide, okay, only. Okay, so just quickly, okay, I think we have probably 3 minutes more, okay. Any questions, okay, before I go quickly on the this afternoon? This afternoon session. Ada soalan? DVM 3 tak ada soalan lah. Saya ajar DVM 1 online last semester, banyak soalan.
Doctor, I actually have some questions.
Yes.
But I emailed you.
Okay, sure. Yeah, I haven't replied your email. Cause I was too busy, but I'll try to reply as soon as possible. Okay, all right. So I will go through the online presentation flow. Okay, for quickly. Okay, I know you have another lecture after this. Okay, So, alright. So, I will open the meeting room at 2:15. Okay. Hopefully we can start at 2:30. Why I want you to come in early? Because I need to assign you into 3 different rooms. Okay. So it will take up a bit of time because there are 100 over of you. Okay. So please come in at 2:15. Okay. To assist me. Okay, so that if everyone is in, okay, it's easier for me to assign everyone at the same time. Okay. Okay. When you come in, please. Okay, I cakap 10 kali dah ni. Rename yourself as this one. Okay. Jangan K kat depan ya. I want the group at the front. And jangan mix up K dengan group. Okay. Group antara group 1 to 9. Okay. K1 or K2. Okay, because last week, actually some of you actually pergi bubuh K9 lah, K8 lah, okay? When I'm trying to assign you, okay, it is difficult, okay? So please, okay, group first, group 1 through 9, and then K1 or K2, and then your name and your metric number, right? So these are K1, K2, K1, K2, K1, K2. So there are 3 rooms. So this, I will place you according to this, okay? So the K2 will present first because last time K1 present, so K2 will present, okay? So I want you, bila you masuk dalam these different rooms, I want you to assign one timekeeper, okay? Timekeeper 15 minutes, okay? Because I don't have so many manpower untuk letak dalam setiap room, okay? So it's just the 2 of us, me and Prof. Aro. So one of you needs to be the timekeeper in each room, okay? So 15 minutes, okay? So group 1 will present first, okay? Group 2 will present later, group 3 will present last, okay? So the same with this, okay? So you will present concurrently in different rooms, okay? So this K1 will listen lah or ask question, or even yang katalah group 1 yang present, group 2 K2 nak tanya pun boleh, okay? Everyone can ask, okay? In the room. So it's 15 minutes each group, so 45 minutes total. So I letak plus minus 1 hour lah because nak assign semua, okay? Nak share screen. So it will be 1 hour, okay, for the first session. So after the first session, okay, I will ask you guys to go back in the main room, okay? And then we will break for 10 minutes, okay? So around 3:40, okay, we will start the second session. Again, I will need to assign you into different rooms, okay? Because I want mixture, okay? Tadi you dah dengar orang ni, so you nak have different momentum sikit dalam different, what we call it, different chemistry, okay, in the room, okay. I put another, okay, combination, okay. So this time K1 will present, K2 will listen, okay. So group 1, group 2, group 3 will present, okay, accordingly, okay. And then the same with room 2, room 3. So at 4:40 we will finish, okay. We will go back to the main room, okay. I will send broadcast message to everyone. Cakap, okay, you have 5 minutes to wrap up, okay. Then we will go back to the main room, okay. Sama dengan this one, okay. So bila I cakap wrap up tu wrap up lah, okay. And then we will have debriefing session. So we will debrief all the cases, okay, at the end of the session. So basically, you guys will listen to your own case, okay, from other groups, and then the other 2 cases, okay, from 4 groups lah, okay. Betul tak? Sebab group 1 will listen to group 4, okay, group 5, group 6, okay, and then dia pun dia dengar daripada group 2 and group 3 from the previous session, right? Okay. So basically you will hear 5 different presentation. Versus before this, you hear 17 different presentation. Okay? Right? So, don't worry about us. Okay, we will jump from one room to another room. Okay, kalau kita orang tak ada, just continue. Okay, I will open up 2 laptops. Okay, Prof. Aro pun will open up 2 laptops. We will jump in from one room to another. If we don't have questions, you will actually, during the face-to-face session, you guys are the one that asking question, not us. Okay, bila kita buat dekat Physiolab, okay, so it's actually you guys. Okay, we will just interrupt when there something that we are not clear of. Okay, then we will actually raise up, okay, questions. Okay, so any question on that before we adjourn? Okay, I'll try. We will come in early to actually answer any questions later before we start the session. So for now, ada questions tak?
None from me, doctor.
Okay, alright. Then I'll see you at 2:15 this afternoon.
Okay, doctor. Thank